program and to give trainees the opportunity to speak about their research and present and develop those skills, because they're so important. And we saw that in our, hopefully in an alumni session, where you saw that you can maintain some research activity, you can speak to it in different events, you can be invited to things like this, or to conferences, or to teaching, or within even your clinical jobs to different teams. So it's a great opportunity for all of you, and if there's more like this in the coming years, I will encourage you to take that opportunity and make the best of it and try and present on what you do. So our first speaker is Callum. Callum, do you want to take it off? Thank you.
Hi everyone. So I'm going to speak to you about my research project, which is titled The Experience and Perspectives of Young People on Factors Influencing Desistance, Utilising an IPA Approach. So first of all, just kicking off with the research team. So you have myself, second year forensic line trainee, Karen McEwen, who's academic supervisor, Jennifer McDonald, FCAM's clinical lead and field supervisor, and a special thanks to Diane Fraser for the initial project idea, Sinead Taylor for being the uni sponsor, and CYCJ and the FCAM's team for their involvement in PPI and the development of patient-facing documentation. So just kind of kicking off a little bit of the background. So desistance is so commonly referred to in kind of criminology literature, but it means nothing to a lot of people. But it's often kind of illustrated as a process and journey of change from offending to non-offending, and the illustration of it being a journey is really to highlight the complexities of it. It's often very individual to the person, categorised by many lapses and relapses, and needs really kind of focused management. So when we think about kind of trends of offending, what we know from research is, and one of the most consistent things from research, is that crime tends to peak in adolescence and then tail off, which has really negatively implicated how researchers look at and study desistance in young people, with a suggestion that there's no need to do it because eventually they'll stop offending regardless. So that has then led to theories of desistance in adults being applied to children, which is kind of counterintuitive because it relates to factors such as autonomy and relationships. So there's limited research with young people who offend, and data often collected is around adults reflecting on being a young person and then what factors they think might have supported that desistance journey, but not looking at the young person as the experiences happen to them. And there's an absence of mental health mentioned in many of the literature. But we do know that prevalence rates are often higher with young people who offend, from 25 to 81%, reaching up to 95% in custody, and rates of neurodevelopmental difficulties also being found higher in this population. So what am I going to do? I am aiming to look at and explore experiences of desistance in young people, looking at the interventions that are used and how they might make sense of their experience, and doing that through an IPA methodology, so the use of semi-structured interviews, aiming to recruit between 5 to 8 young people from the FCAM service in Glasgow. And we're not asking for carers or parental consent. What we're doing is kind of assessing competency to consent, both with the MDT and myself, which has been a bit of a sticky situation for ethics, but never mind. So yeah, that's really where the research is to date. We don't have any findings, and only just went to rec on Wednesday there. So some of the reflections on learning, so thinking about kind of demographics and anonymity. The service is a really small service, so having to be really careful as to what data is collected in terms of demographics and then what's reported on, so the people who are in the service can't then identify the participants when it comes to final write-up. Thinking about patient and public involvement, this is kind of came left field for a lot of people. Although recognising it's important within decon site timeframes, it's actually become quite burdensome for some of the services to get back to us in time, and we want that to be kind of beneficial to them and not a burden, which has been some of the feedback. And finally, just the importance of the research. Nothing's been really done in this area with these young people who are often marginalised, very traumatised. So it stands as a unique piece of research to give a voice to the often unheard, centering them at what helps, what supports, and what can kind of support policy and support for them going forward. Thank you.
Thanks so much, Callum. So I forgot to mention that the form, can you hear me all the way there? No? Sort of? So we have to wait for this? Working? Yeah, there you go. So the format is keep your questions in mind. We're going to run through the 5 presentations. That was the preference for the presenters. And then we'll have all of them stand up for you to ask your questions and make comments. Okay? So keep your questions in mind because they're really looking forward to hearing those and answering anything that you have in mind. Okay, so for our next speaker, I'm just going to pull up the slides here. So Megan. Welcome, Megan.
Thank you. Where's best to
stand? If you want to take the middle, that'd be great.
Yeah.
And I can move the slides for you.
Okay, thank you. Hi everyone, I'm Megan. I'm a third-year trainee, and I'm going to be talking about my MRP, which is exploring climate change anxiety in young people, which is a project I developed with Jala, my research supervisor. Yeah. So data collection for this just finished last week, so I don't have any results to report just yet, but I'm going to just talk briefly about the background of this project, the aims, the methods, what the plan for the analysis is, and then also some ideas for implementation, and then briefly at the end, just some lessons learned from conducting research. So there's lots of research coming out over the last sort of roughly 6 years around the mental health impacts of climate change. And this systematic review by Coffey sort of summarised how lots of these terms are still quite poorly understood conceptually, but are getting thrown around quite a lot in the literature at the moment. Thanks. So climate change anxiety is being defined as the emotional, cognitive and functional difficulties related to the threat of climate change. And it's important to note that the literature is encouraging that we don't pathologise climate change anxiety. It's a normal and functional reaction to the serious issue of climate change that can help motivate people to take action. But similarly to generalised anxiety, for some people it might be overwhelming and become potentially maladaptive, where it's sort of discouraging people from taking action and also impacting daily functioning as well. Thank you. So the literature is also shown quite a bit that young people are particularly vulnerable to climate change anxiety. They're the ones whose futures are going to be most effective, and they have even less control over the situation than adults do. However, the impact of climate change on young people's mental health still remains understudied. So Clayton and Crozier developed this measure of climate anxiety, the climate anxiety scale, and they're one of many studies that's also starting to show this association between climate change anxiety, generalised anxiety and depression. But that's leading to this question of, if there's this overlap going on, how much can we define climate change anxiety as a unique construct? So that leads to my project, where the aims are to explore the degree to which climate change anxiety differentiates from other mental health domains, specifically generalised anxiety and depression, and also to explore if there are associations with transdiagnostic mental health factors as well. So we conducted a quantitative survey of young people aged 16 to 24 in the UK and distributed it online and through colleges and universities. And these are the measures that were part of that survey. And the transdiagnostic factors that we are looking at is tolerance of distress and tolerance of uncertainty. So the plan for the analysis is a confirmatory factor analysis, and this really allows us to test the underlying constructs of climate change anxiety and different models of that construct in relation to generalised anxiety and depression. And on the next slide I've got some pictures that will help explain that further. And then the aim is to expand on that with a structural equation model, and that's to help then explore how the best fitting model will associate with the transdiagnostic mental health factors. So these are the 3 models that we're testing, and it's really to sort of test whether climate change anxiety is best fits within this overarching unidimensional model of internalising psychopathology, or if it's better understood as a separate domain to generalised anxiety and depression, where they're correlated but multidimensional. Thanks. So there are some theoretical implications to this research in terms of helping us just understand that underlying construct to climate change anxiety within how we understand current domains of psychopathology, and it helps us see how we conceptualize it in young people. There are also some then practical implications to this, helping us understand how young people might be psychologically impacted by climate change, how climate change anxiety might emerge within our clinical practices as well. And hopefully this can also help inform future research, particularly into how we can then support young people who might be struggling most with climate change anxiety. So just a couple of things that I've reflected on whilst doing this research, and my systematic review as well. So firstly, for my systematic review, it's quite hard finding a research question that had a suitable scope for the systematic review. So just sort of coming back to the key parts of the literature and what they suggest is needed for future research was really helpful for identifying those gaps. Keeping a critical eye, we've got to read a lot of papers doing these research studies, and it's tempting sometimes to just sort of read the conclusions, just read the abstracts, but we know that those conclusions being made aren't always the most valid, so trying to keep a critical eye. Networking with and learning from other people researching in the area that you're exploring. Jal was able to set me up with the Climate Action Network, which is a network as part of the ACP, and I attended an event that was really helpful for understanding how other people are understanding these concepts and what areas they're researching in, so that was really helpful. To practice describing your research, that really helped me wrap my head around what I was researching and how I explain it in a non-jargony way, which is hard sometimes. To keep focused, these are really huge topics that we're exploring sometimes, and with climate anxiety there's so much coming out. Even since I started this project there's loads coming out, but trying to just keep focused to what my research question is specifically, and I'm knowing I'm not going to be able to read and write about all of it. And finally, just keep sharing with everyone, keep talking to people in your cohort and in different cohorts. I find the research can be a more isolating part of the doctorate as a whole, where you're kind of more on your own, doing your own thing, but everyone else is also has the same struggles, is going through the process as well. So keep talking to each other and keep venting about whatever it is that you're struggling with, and it's really helpful to be able to lean on each other in that way. Thank you.
Thanks so much, Megan. Next up is Naomi.
Yeah, let me just add it to it.
Okay. I'm just going to do the slides, Stella, yeah.
Sorry.
Will you do the slides?
Yeah, I'll do it.
Yeah. Okay. So my name is Naomi and I'm a third year trainee, and is that echoing, or is it okay? Is it okay? I am on an APL pathway, so I have just handed in my thesis and had my viva, so I'm going to talk about my MRP and some of the findings of it as well. So my MRP is about measuring the experience of psychological consultation to residential staff who work in children's homes across Scotland. So the outline of the presentation is I'm going to talk about some introduction, the background, the aims, the methods, the results, and then some of the implications of the research as well. So, as I say, my research is about psychological consultation to residential staff. So, across the United Kingdom as a whole, consultation to the systems around care experienced young people is really commonplace. So, those of you maybe who have been in placements and CAMS would know that often consultation is provided either to social workers, residential carers, about the young people that they work with. So what we know is that children who are part of the care experience, so whether they're in foster care, kinship care, or in a residential home, have poorer outcomes in terms of, social outcomes and mental health outcomes as well than the general population. But also research has shown that those young people who are looked after in residential homes are at even greater risk for adverse outcomes compared to those young people who are in kinship care or foster care. So it's a particularly vulnerable group of people who maybe require additional support. So the staff that work with the staff that work in residential homes are also particularly vulnerable. It's a very demanding job, as any care job is. This is a staff group that's susceptible to burnout, secondary trauma from what they're experiencing, and often these young people present with a lot of internalising and externalising difficulties that can be challenging for this staff group to work with. So consultation is commonplace, with the idea being that psychological knowledge is given to the systems around these young people to help the staff understand about attachment, developmental trauma, and it's often underpinned by attachment theory as well. So that's the theory behind it. And although this is commonplace and there's often service agreements between the NHS and local authorities that psychologically informed consultation will be provided, there's a very limited evidence base in this area. And whilst I was looking into this and looking into the research, identified that part of this reason that there is quite a poor evidence base is that there is no measure, no way to assess whether these staff groups actually find consultation beneficial or what the actual impact of it is. So next slide please. So then the aim of my MRP was to develop a tool to measure the experience of psychological consultation with residential carers working in children's homes. So I've had two main research questions. So I've called my measure the Experience of Consultation Questionnaire, the ECQ. So the first research question was to basically develop the ECQ and identify whether it yields reliable total and subscale scores, and also to look at whether specific aspects of consultation were associated with caregiving domains. So what I did was develop this tool, but also measured reflective capacity, self-efficacy, and levels of burnout in residential carers, and to see whether there was any association between consultation and these caregiving domains. So that was the secondary research question, yeah. So I'm just going to talk about the methods, so how I actually designed this measure. So the Experience of Consultation Questionnaire was firstly developed by extensive review of the literature to identify what, if anything, was out there to measure psychological consultation. So there was two studies which had sort of made a preliminary measure of psychological consultation, but there was methodological limitations in their study. So the main way we developed this tool was myself, Jala, who's my supervisor, and two clinical psychologists working in NHS Highlands Care Experience team. Basically, through numerous meetings and discussions, met together and developed these 22 items which we felt captured several domains of the consultation experience. And once we were happy with these domains, we clustered them into these items, we clustered them into two domains, which we conceptualised as they're experiencing during the consultation. So this was items like, did you feel respected? Did you feel valued? Did you have enough time to talk about the young person you were working with? And the after consultation domain. So these items looked at things like, as a result of the consultation, do you feel you have a better knowledge of developmental trauma, or do you feel better equipped to manage challenging behaviour? And then what we did was we piloted the tool with two residential carers just to see whether they felt the items were appropriate, did they actually capture what their experience of consultation was, and just looked at things like, was it too jargony, was the language appropriate, and made changes based on their recommendations. And then the second phase of the study was to actually give this ECQ to residential carers. So the recruitment was based across NHS Highland and Argyll Bute Council, Highland Council, Argyll Bute Council, and also we recruited a third sector children's home called Aberlour Childcare Trust, who have about five homes across Scotland. So that was the participants in the study. Next slide, thank you. So the results. So I used quantitative analysis to look at the findings from the survey. So I managed to recruit 61 residential carers who were working across these local authorities and Aberlour Childcare over an 8-month period of recruitment. So there was a lot of trying to do regular reminders, encouragement. There actually was probably a much bigger sample of people, but as everyone probably knows, it's really hard to recruit people to complete surveys. So I'm still happy with 61 people. And then the results were that the experience of consultation questionnaire yielded overall reliable scores, and the individual items were all found to be worthy of retention, and we looked at things like ceiling effects, floor effects as well of the ECQ. So as I said, we sort of separated it into during consultation and after consultation, and we looked at whether these domains were associated with the caregiving factors and found that the after consultation domain of the ECQ was significantly associated with self-efficacy, even when controlling for levels of staff burnout. But there was no significant association between reflective capacity. And it wasn't the main aim of my research. Initially I had intended just to have local authority children's staff, so basically people who are employed by the council, but because recruitment was difficult, I then included privately run children's homes also. So I conceptualised the findings between those staff who received consultation from the NHS and those staff who received consultation from privately employed psychologists. And interestingly, those staff who received consultation from the NHS, so they were employed by councils, reported higher levels of burnout and that they didn't receive as frequent consultation as those in privately run homes. So that's something that's interesting to look at in the future. So the implications and conclusions of my MRP. So I think it is advanced to study psychological consultation, something that's very commonplace across the UK, but this is the first sort of tool to measure this experience that's actually looked at the psychometric properties, although it's very exploratory in its design. I think my study provides a valuable insight into actually what is this experience for this really vulnerable staff group of receiving this consultation, and actually thinks about its evidence the link between consultation and self-efficacy, which I think is the first study to do this as well. And also, due to the large increase in privately run children's homes across Scotland, if there's going to be more privately run children's homes, it's important to look at the difference between these staff groups and actually what is it about local authority children's homes that makes maybe burnout higher, or what are the factors that might contribute to this. And then my key reflections. So even if you think your project is really straightforward and it isn't risky at all, NHS R&D might have a different viewpoint. So initially we planned to make it a multi-site project, including NHS Lanarkshire and NHS Highland, but R&D advised just going for one health board first and then making it a multi-site project, but unfortunately just due to time constraints that it took them to review the documents, this wasn't possible. So I would advise you, if you're doing anything that requires IRAS and R&D, to get in as early as possible with your forms. It's really challenging to recruit this staff group in research. They're a really valuable staff group that we want to try and protect, try and support care experienced young people, but actually we need to think about, well, how do we involve them in research more, how do we involve service users in this research so it's valuable for them. A main thing for me is I found my MRP a great opportunity to build connections with people in academia and the NHS. I've recently got a job working with the Care Experienced Young People team in NHS Highlands, and I think this project was very influential in sort of making those links with those people. And for me, going into this field, I feel really positive that I've already got some connections with these children's homes that I'll be working with through my MRP. So yeah. And then I just want to thank you to the field supervisors. We've been talking about that today as well, about maybe becoming field supervisors, and if it wasn't for Clodagh and Penelope, who are the psychologists in NHS Highland working within this team, I never would have had the opportunity to do this project. And also thank you to Jala and Andrew Gumley for their support in it as well. Thank you.
I have to say, all of you have been keeping the time. It's great.
Hello? There we go.
All right.
So, hi everyone, so I'm Joanna and I'm a second year trainee, and my MRP is looking at an evaluation of a programme for carers of people with anorexia, and it's a feasibility study. So a bit of the plan for today, so we'll do a bit of background, go into the methods, got some preliminary findings I can share, and then some key reflections on the research. So a bit of background, so we know that carers and family members provide long-term care for people with eating disorders, and we know that they're at heightened risk of anxiety and depression, and what can happen with this is that sort of high level of emotion can come out in sort of unhelpful communication strategies. So that can be the carer becoming quite critical of the person, so why can't you just eat, and unhelpful communications like that. Or it can also come out as sort of the carer becoming quite overly emotionally involved and overprotective of the person with anorexia, so doing everything for them, really sacrificing their own well-being to care for this person. So we know that we need to take care of carers so they can take care of themselves and they can also take care of their loved one as well. So what's out there? So there's not a lot of carers interventions actually out there for our carers. The majority of the research is based on this collaborative skills workshop, which was developed by Janet Treasure. And what that is, it's basically teaching carers communication, problem solving, motivational interviewing strategies. And the findings are mixed, so some studies have found that it's associated with reduced distress and reduced levels of expressed emotion, so that's that sort of critical overprotective communication strategies. However, when it's compared to your sort of standard psychoeducational workshops, they haven't found any significant differences. And it's also not specific for anorexia, so there's no interventions out there for carers with anorexia, particularly at that sort of moderate to severe treatment resistant end, like Emma was saying earlier. So that led to the development of the current project. So it's a carers intervention for people with anorexia on that moderate to severe end, or treatment resistant, or with comorbidities as well. It's based on schema therapy, so the reason for that is we know that schemas, or negative schemas, like those really entrenched beliefs about the self, are involved in the maintenance of treatment-resistant anorexia. And it's also, there's an emerging evidence base that's used to treat complex EDs as well. So we're using sort of psychoeducational, group discussion, some experiential techniques in that as well. And it's 12 online sessions facilitated by 2 clinical psychologists, and we've done 2 cycles so far between September and February, with a 3rd one currently underway. So the purpose of the study is a feasibility, so we just want to know, is the intervention actually feasible? So can we recruit participants? What's the retention like for the intervention? Can the intervention actually be delivered with adequate treatment fidelity? How acceptable are our outcome measures? Are people filling them out? And then also we wanted to sort of define the sample for the carers that are accessing the intervention. So how are they scoring on the various outcome measures that we're using? So as I said before, it's feasibility design. We've done 2 cycles, 3rd one underway. It's for partners, spouses, family members of someone with treatment-resistant anorexia. We've also invited patients to complete some outcome measures as well. However, obviously they're not involved in the intervention, but we just want to get a sense of what the patients that they care for look like. So we're aiming to recruit between 8 to 10 people per cycle. We've got 8 NHS sites that are helping us with recruitment, so 1 inpatient, 7 outpatient, and then we also had Beat, the ED charity, who done a bit of advertising for us as well, which was nice. So in terms of how we're going to define the sample of carers, we have loads of outcome measures, but I'm only focusing on some of them. So the schema mode inventory, which is looking at the schemas of carers, family questionnaire, which again is looking at that expressed emotion, depression and anxiety, the eating disorder impact scale, and then the EDQ, which is for the patient study to sort of define their eating difficulties. And we're administering that before intervention, halfway through, at the end, and then 3-month follow-up. And we've also got little brief session rating scales that we're doing before and after each session as well. So we've got a lot of outcome measures. So I've got some preliminary findings that I can share with you. So the first one's the healthy adult mode. So that's from the schema inventory. And what that is, like Emma was saying earlier, it's sort of that part of ourselves that is wise, that can be self-compassionate, that can sort of be self-directed and prioritise our own needs. And we know that that part is really underdeveloped in people with anorexia. And interestingly enough, in 72% of our carers, that part was also reported to be underdeveloped as well. And then again, if we look over expressed emotions, so 76% are reporting really high levels of emotional over-involvement, which again isn't surprising given the previous research. Interestingly, our carers were scoring quite low on anxiety and depression, so I think there'll be further work to sort of unpick that a little bit and see what that's about. And then finally, in terms of the impact of the eating disorder on functioning, we found that it has the biggest impact on family meals, which again, it's not surprising. But interestingly, I've not ordered this correctly, but here it actually sometimes often impacts on carers' feelings of guilt. So again, thinking about that sort of emotional over-involvement, you can see how that sense of guilt might pull the carer into that mode. And then in terms of the feasibility, so we had 20, this is for the 2 groups that were run, we had 20 carers that came to an information session. So in terms of recruitment, therapist approaches patient, gives them an information sheet, invite your carer, and then if the carer wants to get involved, they get in contact and then they have an information session where they're screened and then come onto the study. So we had 20 across the 2 groups. 2 people didn't consent, so they dropped out, so we're left with 18. And then in terms of our actual groups that we've run so far, we've had 8 dropouts, 4 in each, which is, relatively high. But for the majority of people that did stay on study, they were completing between 9 and 12 sessions. Okay. So next step, so we want to, again, just look at recruitment retention for the 3rd group that's running. Look at our treatment fidelity measures, have a look at the outcome measures for mid, post and follow-up. We have a really small sample size, so we can't really look at whether it's effective or not, but I think it'll be interesting just to sort of summarise how people are scoring at the different points for preliminary evidence. And then we'll look at acceptability of our outcome measures. So in terms of some key reflections for the project, so it's felt like a really hands-on project to do as your MRP, because I got to sit in and shadow the first group, so that was 12 weeks, and got exposure to schema therapy, which you certainly don't have in 1st and 2nd year. I don't know if you get it in 3rd year, but so I've been doing a lot of learning on schema therapy, which has been really interesting. I've also had the opportunity to sort of administer the treatment fidelity measures, so yeah, I think it's been really good to just be part of an NHS clinical trial in a sense, and you're looking at, as opposed to sort of just looking at the numbers and the data and not really having an idea of, right, what's actually going on in these groups, like what do they look like, and so it's been good to sort of marry that up and sort of embody that scientist practitioner role, which it's been a really good MRP in that sense. And yeah, I think as well just been part of that wider NHS research team, so research assistants with different recruitment sites, seeing how all that works, learning about funding, which just sounds awful. It's been eye-opening. But yeah, that's me.
So our final presentation is by Natasha.
So yeah, my name's Natasha. I'm a final year trainee, and my research is looking at people with intellectual disabilities and their experience of using the internet to find things out about sex and relationships. This project is supervised by Andrew DeHoda, who has not snuck in to see me yet, so that's good.
He was here for lunch.
We'll say that earlier. And I have a field supervisor up in North Highland as well. Just a small caveat before we get started. When I signed up to this presentation, things were going very much to plan in recruitment and people's interest in the project and wanting to take part, and I was like, this will be a great idea, I'll stand up, it will be April, everything will be done, everything will be sorted. Obviously that's not the case, that's not what has happened. So today is very much on early reflections, kind of thinking around what I've learned, lessons going forward. So my recruitment is still very much ongoing, but we'll go through the project and you'll get to find out more about it. So today I'm going to talk about introduction, so why I was interested in this project and kind of what the main kind of studies and things in the area are. We'll think about the methods, so the design and things that I've gone with, and early reflections, not results, and also think about some of the challenges in the area as well. Thanks. So, the internet, I'm sure you will all agree, has changed everything. I feel like the way that we live, so the way that we shop, kind of click and collect, deliveries, the way that we bank. I'm sure many of us have online banking apps on our phones at the moment. It's also changed the way that we order food. So recently when you go to restaurants and they have a little QR code on the table and you're like, well, where's the menu? This is not like it used to be. It's also changed the way that we navigate. So when we're out and about, kind of find different places, kind of Google Maps, Apple Maps, kind of that kind of functionality. I know that I'm telling you things that you already know when you do in your day-to-day life. So change the way we watch TV, change the way we find out information, change the way we I feel like sometimes when you go to places, the main thing you're asking for is, how do I connect to your Wi-Fi? What is your Wi-Fi password? Just to acknowledgement that actually things have changed quite a lot, definitely in my lifetime. Yes, next slide. Sorry, thanks. And, unsurprisingly, it has also changed the way that we communicate with our friends, our family, and kind of romantic partners, and also how we find them as well. I want to do a quick hand survey about people that use dating apps in the room, but I figured that maybe would not be appropriate, so I can cut that bit out. But I guess just to try and introduce people to the idea that actually how we connect with other people is very different now to maybe what it was 5-10 years ago. And just a sense that not even how we connect, but how we communicate, kind of the rise of social media apps, different WhatsApp, Instagram, Facebook Messenger, all these different platforms are now so different to what they used to be. And they're just an awareness that actually that has changed, which brings me on to the next slide. Thanks. So, considering that the internet has changed literally everything, there continues to be what we call a digital divide. So whereby young adults, young people, actually not even just young people, adults, intellectual disabilities, don't have the same level of access and use with the internet as people without an intellectual disability do. And some reasons for that have been given around kind of the functionality of apps. It can be quite difficult to use, the lack of education, lack of skills, kind of training about how you navigate some of these difficult apps. And also there's this idea of gatekeepers, so parents, carers, residential workers, professionals, all kind of acting very much as gatekeepers for people with intellectual disabilities and being able to access the internet, being able to have their own access to laptops, smartphones, and actually that has created this, what we think the digital divide is. But it's a growing field of research, so we know quite a bit about what people are using the internet for when they do have access. So it is around, I guess, what we also do to communicate with our friends and families, and also potentially for romantic interests as well. But a large amount of the research is focused very much on risk. So the risk for this population, I guess, using the internet, kind of scams, romantic scams, financial scams, and just generally focus very much on what's that negative side rather than thinking, okay, what's good about the internet, what actually opportunities are there that maybe were not there before. And some previous research has found actually the internet is a place where we can kind of all be like everybody else, and actually that opportunity therefore is really important to think about. And so, related to this, we also know that in this area that sex education is not great for people with intellectual disabilities, and very much in the sense this internet is a place that we go to find things out. So eventually I want to know how and if the internet is being used to find things out about sex and relationships in young adults with a mild to moderate intellectual disability. I forget that I didn't put my research question on the slide, but anyway. So the method, this is what I propose. So it's an interview qualitative style approach, hoping to recruit 10 ideally participants, but 8 is my minimum. Going to record the interviews that I've done so I can transcribe them and then analyse them to look for themes using reflexive thematic analysis. I try to make this as fun as I possibly can for participants, because I know that it's very awkward when you don't know someone to come along and talk about what you're doing with the internet and actually how difficult that can be for people to do. So I've created a logo quiz, which sounds much more complex than it is. It's just all the different logos of different apps printed out, laminated, so then just start facilitating that discussion. Just finding out which apps people are using and what they're using them for, if it's been bad, if it's been good, and what they think or feel about them. And looking for participants who are engaged in kind of further and higher education across. It has mainly been in the Highlands because that's where I'm based, so that's where I'm recruiting from. So, as you know, it's not finished. So what have I done so far? So I've recruited 6 participants so far, and I have a 7th person who is interested, and we're just trying to sort out a date so I can go and see them. And engagement with the subject area has been really, really positive, which for me, obviously, that's a great thing, but it's also been quite a surprise, the amount of information that people are willing to share and kind of disclose and speak about really difficult and really personal experiences that people have had. Great for my research, but also a surprise, just at the willingness of people's openness. Since I wrote this presentation earlier this week, I've actually spoken to 8 organisations. So it's a fast-moving project, a lot of the times just trying to up recruitment as much as we can. And it's in 2 stages, so I do go along, do information sessions to kind of groups of students generally with intellectual disabilities, introduce the research, they get to meet me, and then I come back and do the interview. So there's a couple of stages. And then before that, there's like chats with the staff at the organisations as well, so it's a bit, it's a lengthy, time-consuming process to go through. Thank you. So, early reflections. Like I said, there's been a lot of engagement from participants about the subject area, and actually just the importance of actually how vital it is to have these conversations with people and find out what people's experiences really are. There's been a lot of discussions where there's been experiences that people have had that have been really hard to navigate, and actually people feeling quite isolated and alone in that, and not really feeling like they had people to turn to for support, both kind of in a peer group, but also kind of from professionals and staff at schools or colleges, for example. And actually something that really struck me was that there seems to be quite a lot of shared experiences between those with an intellectual disability and those without, which is not who I've interviewed, but just from reading the literature, that actually lots of these things come up for lots of people about how to navigate the internet, how to navigate people messaging you that you don't know, with people sending inappropriate messages, inappropriate images, and how actually difficult that is to understand and contextualise and understand what's going on and then how to respond to it. Which is not something I'd really thought about before doing the project, about what maybe might be shared or what might be different in these kind of 2 different populations. My second reflections, see there's a lot of learning, even though they're not findings. Confusion from professionals about what we do about the internet, how we teach our students in colleges about how to navigate some of these situations. So when I've done these kind of first initial kind of chats with staff, have always been like, oh, this is really important, like you really need to come talk to our students, like we don't know what to do, and they'll kind of talk about an example student where this has happened and that has happened, and they're like, we didn't know what to say, we didn't know what to do. And actually just really bringing home that people don't know how to talk about this, they don't know how to talk about internet use, they don't know how to navigate, especially when it's something more risky or more negative experiences that people have had. It's like, oh, how do we handle this, what do we say? And just finding a way to make that make sense for people. Unsurprisingly, social media is being used across all the participants that I've spoken to, different apps, and mainly to keep in touch with friends and family, but also with people friends they've made online through just either messaging them on different platforms or through kind of gaming and multiplayer platforms as well. So there's this idea of connection that these people are very much their friends. At the same time, maybe they're not necessarily people that they may have met kind of face-to-face in person. And the role of parents and professionals. So I think what I've been really struck by across the participant group is that when situations have come up that have been quite difficult, or they've been quite risky, or there's been some things that have happened that have not been what they wanted, it's been very much a punitive response by professionals and parents around actually, we'll remove the devices. And I think what I've really found in the research is the impact that has had on the individual themselves, of being like, well, maybe they didn't do anything wrong, but they're the ones that got the device removed type thing, and actually that being quite difficult for the individuals to even talk about, but just to acknowledge that actually that is what they're experiencing, and how do we, I guess, help support the people that are supporting them to find maybe a different way forward, so that, yeah, the feelings, I guess, they're not left with being like, actually, well, I'm to blame for this thing that has happened, and actually maybe it wasn't them that did it, it might have been someone else, so just thinking around how we navigate that. Challenges, there have been many. So the subject area, although very important, you can hear like the awkwardness when I'm in these conversations. I'm like, I want to come along and talk to students about sex and relationships. And you can just feel like the cringiness, the awkwardness of being like, oh, well, it's really important, but we don't know about that. Maybe that's not quite appropriate. And I think historically in this area, this group of individuals have been, there's a fancy word for this, I'm sure, but have not been looked at as having a sexual identity, and their sexuality has not been important. But actually, we now know that that's not true. It's something that they do value. But yeah, there's just been lots of awkward moments I've had over the last few months when you're like, oh yeah, that's really what I want to do. And secondly, it's been quite a challenge, I think, to find different ways of asking people about their experiences of using the internet for relationship, sex, sexuality. You're trying to find a way that's not like leading, that's saying, oh, is this good, is this bad, like how do we navigate that? I've had some very entertaining responses from my participants, which have been great. We're just trying to think about what language is appropriate to use, how do I ask you these questions without leading too much to get them to say what maybe they think I want them to say. Getting in touch with relevant staff members and organisations, again, research never goes to plan. And that's been quite hard, kind of being signposted around different people, trying to find the right member of staff to then set up like that initial conversation. And the long-term impact of COVID, service delivery has kind of changed quite a lot, especially in the Highlands with the rural nature. Things are now maybe done online, maybe they weren't before. So people are not necessarily coming together in order to kind of hold those information sessions and have those kind of initial conversations. And then the last thing that's been fairly challenging is around this idea of adults with guardianship, and to explain something that's actually quite complex, quite simply. So adults who have intellectual disabilities, and lots of them are under guardianship, where someone else in their life has taken responsibility to make kind of welfare and financial decisions, primarily for their safety, and to keep them safe. So in order to take part in research, what I've done is want people to be able to consent in their own right, which we and my supervisors felt was a really important part of the project. So adults under guardianship can't take part in the project as the way that it's been set up, which hasn't been an issue in the first kind of round of recruitment, but coming into the second bit now, trying to up recruitment, there are a lot of adults who this applies to, and actually working out whether or not they would be eligible or not eligible, and just some of those conversations around that. It's the end of my presentation.
Come up, please. I have to say thank you so much for those really exciting and engaging presentations. Maybe best over there so that we don't interrupt interpreters. I think all of us can say that the excitement really came through your presentations, and I know some of you who are further in the process have highlighted challenges of carrying out a research project in a demanding program over a period of 3 years. But what's great about all of them is that there is light at the end of the tunnel, and clearly you've had loads to learn from the experience. And even for us who are leading careers that are based on research, there will always be challenges and there will always be pitfalls, and it's about kind of finding a team, finding supports, thinking of alternatives, and being creative with how you approach it. So thank you for that. Loads of learning, loads to think about, and I'm hoping there's some questions or comments. And thank you for being, the first presenters in a cross-cohort training day. Really appreciate it. All right.
Yeah, thank you. Okay, so first of all, thank you very much all of you for sharing your amazing projects, and especially for the reflections. And I guess especially for, first of all, for the first year, it's very important to identify the difficulties that you experienced. So I have actually 2 questions, I'm sorry for that. So the first one is for you, Callum, so the first presentation. And you said in the introduction that and your developmental difficulties are more prevalent in your population, so for people that are offending. Could you just expand a little bit, because I think this is a really important point there and a really interesting finding. So, yeah.
Yeah, so I think just across the board, when you look at forensic populations, rates of mental health and neurodevelopmental difficulties are kind of really prevalent. They're often really understudied as well, so what you find as well, early research into like fetal alcohol syndrome spectrum disorder as well showed that potentially up to 51% of the prison population have that. So you have a population whose needs are largely understood as kind of criminogenic, so people only care about the risk and don't really care about kind of what's impacting the person or the formulation about why they might end up offending, and it often goes underdiagnosed or missed. But we do kind of know now that those rates are higher, but I mean it's a guess as to what the rates of them actually are, unfortunately. Does that answer?
Yeah, absolutely, thank you. And the other is for Natasha, for the last one. Yeah. So my question is about your participants actually. So obviously your population is people with intellectual disabilities, and we all know that intellectual disabilities and your developmental conditions are highly comorbid. So I was just guessing whether you would include, and you are including in your research, people, for example, who have intellectual disabilities and autism or ADHD, or whether you exclude those and you just focus primarily on the IDs.
Thank you for your question. So I have included young people, young adults where there has been a comorbid diagnosis, so it wouldn't be enough to exclude you from the project. What I'm trying to do is just so at the start of the interviews I have like a demographic questionnaire where we kind of go through it together, so there is there about asking that question. I just felt, so obviously if someone just had ADHD, obviously they wouldn't be included, but if there is comorbid diagnosis, then it didn't feel, I guess, right at the time to think to exclude. And at the end of my interviews, I have been doing a couple of subtests of the WASI, so the abbreviated version. So just doing a couple of subtests to kind of get some information about where people are kind of sitting in terms of kind of cognitive ability and understanding.
Thank you so much. Yeah.
Hi. Thank you so much for doing this. I really enjoyed it. And as a side note, I think you're really good in public speaking as well. I think this is a question for Naomi. So you mentioned that the levels of burnout within the staff working privately versus NHS were higher, lower. Like from your conversation with the staff and from your observations, why do you think that is the case?
Thank you. Good question. So I didn't measure, I don't know why that might have been, but so the reason that attracted me to this project was that I worked as a residential carer with looked after children before getting into the doctorate, and so I don't know, is it about that maybe they're more stretched, there's less resources in publicly funded children's homes. I think more research is required, but it could be that there's less staff to the number of children, but it's certainly something that I think needs to be explored further to find out. What was positive actually, which I didn't put on the slides, is that the measure I used for burnout looked at work burnout as well as burnout working with young people, and both groups reported that they didn't feel burnt out working with looked after young people, which I think was a really positive finding, that they obviously still, there was factors about the job that they found stressful, but it wasn't actually the young people. So it could be, I don't know, long hours, poor pay, loads of things that we haven't really looked at maybe, but yeah, I think it is interesting. Thank you for your question.
Waiting for more hands? All right. I love it when you choose to. No, I'm kidding.
Hi, thank you. It's weird hearing myself, don't like this. Congrats everyone for doing your presentations. Must have been very intimidating with a lot of people in the room, so you did a great job. Also mildly intimidating, people in lower years are way more ahead than us, so congrats to you. The question is for Natasha, sorry. It's just about your participants again. So in your the slide, you said that you specifically chose people that are in further education. And I was just wondering the rationale behind that, because obviously there'll be less people with learning disabilities in higher education, so I was just curious to what the rationale behind that was.
That's a delightful question. So there's a couple of things in this. If I was being super honest, I didn't want to go through NHS ethics. But I was being really, really honest, that might be why, but putting that aside, because probably that was not really the reason. So actually what we found is that there are a lot of college courses that have been adapted or kind of created specifically for young adults that have learning needs or additional kind of support needs or kind of learning disabilities as well. So the sense of thinking, okay, where can we access, I guess, the largest number of young adults that might have an intellectual disability that are not necessarily being recruited from NHS services. Because if I'd recruited from NHS services, there was a risk, I guess, that some of the people I might have recruited would have been involved in interventions that would have been around kind of relationships or around friendships or online use or addictions or all that kind of sort of area. So trying to find a different way of how can I recruit, like where would be the largest population I can recruit, and generally they are in maybe further education, it's not the right mix, higher education, I always get muddled up between the two of them. And we've tried to recruit through third sector organisations as well, but that's proved a lot more difficult just because of the layout of the Highlands and actually people being quite spread out and they're not kind of coming together in the way that maybe they did pre-COVID. And actually it's been really interesting to find out the types of courses that people are doing. So there's a college up in Inverness actually that they're exclusively for young adults that have additional needs, learning disabilities, intellectual disabilities, and actually just hearing the sorts of things that they're getting to learn about sounds really interesting. But yeah, I hope that answers your question.
It does, thank you. Okay. More questions? Yep.
I don't have, oh god, that is weird, isn't it? I don't have a question, but of course I've got a reflection, and it's for Megan. So first of all, I guess well done everyone, like that's really galvanised me hearing about your projects, and my goodness, they're all meaty. So well done, like for getting as far as you have, and obviously Naomi. But for Megan, I guess it's just a reflection. When I was in first year, I was in primary care, and I was working with a young person who presented mostly with, I guess you could say, comorbid generalised anxiety, but it was mostly all based in climate change anxiety. And my supervisor and I were like, oh, okay, how do we really manage this? Of course, we turned to the evidence base and we're like, there's not really much there. So I guess I'm just wanting to say it's really exciting, your research, and I'm really looking forward to seeing what you bring forward, because it's a really big piece of work, but I think it is really relevant, especially post-COVID too, but all of those things that are going on for young people at that transition point and all the difficulties I guess we're facing just now, rising cost of living crisis, climate change, like, you know, it's all going on. So it's going to be really nice to see how you unpick that. So yeah, that's it. So well done.
Great. No, yeah, thank you for that reflection. And yeah, before I got into the doctorate, I was doing volunteering with BEAT, the Eating Disorder Charity, and just doing sort of web chat support. And there was a couple of people who came up within that who were struggling with sort of not typical eating disorders, but eating disorders relating to complete fear of contributing to the climate crisis. And that was something that I'd sort of never come across before, and everyone in the service never come across it before, and I was really intrigued by that. And that was sort of my first experience of realising for young people at the moment how impactful fear and worry about climate change is at the moment. And doing this research has led to so many conversations with friends and family about how much it is sort of that constant thing in the back of a lot of people's minds. So yeah, it's quite exciting that there is this sort of research base now turning a light to that, and some really interesting studies about how we cope with climate anxiety as well coming forward. So yeah, it's just really cool to be a little part of that.
Did I see a hand here?
Great, thank you. I've got a question for Johanna, and if there's time, I've got one for Megan, but I can also take that offline. So I think that's such a crucial piece of work that you're doing. It's just making me really aware of the challenges of caring for being a parent of someone with an eating disorder. And I was wondering, when I saw the baseline measures that you took, if you have any sense, if there is anything out there about a baseline for your baseline. So you talked about 72%, I think, of people didn't have a well-developed healthy adult. What that would look like, because I'm assuming it's not the case that the general population, everybody has that. And I wondered whether there was anything out there so you could have a bit of a sense of comparison for that.
Yeah, so, that's really loud. Yeah, so the way that we got that statistic is